Folks, my name is Paul McNamara. I'm the surgeon here at Hudson Highlands Veterinary Medical Group, and today we're going to talk about cranial cruciate ligament disease in the dog. Cranial cruciate ligament disease is the most common injury in the dog. In fact, we do more knee surgery on dogs every year in the United States than we do on people. It's the most common condition we see here at the practice, the most common surgeries that we do here. So today what we're going to do is we're going to talk about the two most common techniques that we utilize to address the torn cruciate ligament. Before we get started, the anatomy is the same between people and animals. You have a femur, upper leg bone, tibia, lower leg bone, and a kneecap or patella, which makes up the knee. The knee is a hinge-only joint. Inside the knee are two very stout ligaments that appear to form a cross, hence the name cruciates. The one in front is the one that's damaged in this condition. In people, we call this the anterior cruciate ligament, or the ACL. In veterinary medicine, we have to be difficult and different, so we call it the cranial cruciate ligament, the CCL. It's the same ligament, it does the same job, we just give it a different name because dogs walk on four legs as opposed to upright. Here's a model of a knee. So we have the femur, upper leg bone, tibia, lower leg bone, and the kneecap, and the cruciate ligaments would be inside here. When that ligament is damaged, instead of the knee just hinging like it's supposed to, there's now abnormal motion in the knee called a drawer sign. That drawer sign prevents the knee from hinging appropriately. It causes stretching and tearing of the soft tissues, which hurts, and ultimately causes abnormal wear of the cartilage and the underlying bone, which results in arthritis. That's where similarities end. Again, in people, we call this the football player knee or the hockey knee because it's always an acute injury. You're normal 1 second and something happens to you and you hyperextend and blow your knee. In the dog, we now believe that this is more of an anatomically based condition. So oftentimes dogs will have a chronic, progressive, sometimes insidious progression of this disease where they'll be limping for a little bit, they'll get better, they'll limp a little bit more frequently, they'll get a little bit better, and then there's this just gradual decline to persistent lameness. That's because of, again, the way we think dogs' legs are built. In people, the top of our tibia is always parallel to the ground. So when we stand, the top of our tibia is parallel to the ground and our femur is resting on a flat surface. So our body weight is carried onto that stable platform. In the dog, the top of their tibia is not parallel to the ground, but it's on a backward hill or angle. That means that the femur rests at the top of a hill. And every time the dog is in weight bearing and moving, that femur tries to slide downhill. The only thing that stops that is that cranial cruciate ligament. And when I say the term ligament, I don't want you thinking of a steel band or a steel rod. I want you thinking of a piece of rope because a ligament's made up of thousands of fibers, and we believe those fibers deteriorate over time at different rates for different animals. So that's the pathophysiology of the knee. There are basically two surgical options that we look at, and before we talk about them, I'm going to jump forward to the postoperative care because regardless of technique, the postoperative care and the operative care is the same. Regardless of surgery, I'm the one who does the surgery. I don't have an intern doing the surgery. There's not a resident doing the surgery. It's not done under my supervision. It's done by me and my team. I have a dedicated surgical team. I have Jamie, my head technician, who is my scrub nurse, has been with me for about 17 years. Shannon is my nurse anesthetist. She's actually my newest employee, and she's been with me for about 15 years, so we're a pretty stable crew. With both techniques, our patients spend the night in hospital. We do have 24-hour patient care here, so I have a professional in the building, on the floor, watching my kids 24/7, 365. Part of that is a safety factor, making sure they wake up okay. The other important factor to me is pain management. I freely tell people, admit to them that I'm a wimp. I hate pain. I treat pain aggressively, and I will not allow our patients to experience significant pain before, during, or after surgery. So they actually start on a narcotic intravenous infusion before surgery starts. That's continued through surgery and then through the night into the next morning where we try to taper them off into oral medications. Once we can taper them off to oral medications, then they're free to go home. And about 98 or 99% of our patients are able to go home the day after surgery. When they go home after surgery, regardless of technique, they're going to go home with a lampshade or cone. That's so they can't lick at the incision. They will hate it and you will hate it. The incisions are being closed these days with an intradermal pattern. We used to use skin staples, but now we're actually going to an intradermal pattern so people don't have to travel back to the practice at 10 to 14 days to have staples removed. What we do instead is we ask that you take a picture of the incision and a video of your pet and send it to us via email so we can look at it, and then we'll get back to you with the plan from there. Unfortunately, the hard part here is the postoperative care. You're looking, regardless of technique, at about 8 weeks of extreme restrictions. To me, that means the dog is in a crate, pen, or very small room. Regardless of size, you're looking at no bigger than a 5 foot by 5 foot area. There's no running, no jumping, no slipping, no falling, no playing through that entire period of time. I specifically say that you want to avoid or minimize the 5 S's. Stairs, 2 or 3 stairs isn't a big deal. 12 stairs up a spiral staircase we want to avoid. Slippery surfaces, sofas, meaning any furniture, siblings, meaning dogs, cats, or little people, and squirrels. We basically want to avoid them chasing things or running after things. And the problem that we have with my patients is that people will think and then act. My patients act and never think. So we always have to err on the side of caution and protecting their repairs because they can damage the repair. So basically for the 6 to 8 weeks, they're leash walked out to the bathroom and then back into that crate or pen setting. They will go home with 2 weeks of oral medication. They will go home with a short course of antibiotics. And they do go home with some sedatives and some anti-anxiety medication to make those restrictions a little more tolerable for them and for you. And our staff does a phenomenal job working with you to tailor and taper those medications so that they're optimized to each patient. Now, getting back to the 2 surgical options, the technique that we do on smaller dogs and older dogs, and the technique that's actually been out the longest is called the MRIT, which stands for Modified Retinacular Inversion Technique. That technique basically creates a fake ligament. So we go in surgically on the outside of the leg, we go into the knee itself, we remove the damaged ligament, we assess all the other structures, we attend to any other additional problems that are there, and then we use non-absorbable suture that we loop around a bone behind their knee through a little tunnel we create in their tibia to basically create a fake cruciate ligament. That's a very good technique when done in skilled hands. It does have some limitations that it's not considered really an athletic repair. So we tend to do that on dogs that are less than 40 pounds or dogs that are over 40 pounds that are geriatric, not as mobile, or have other comorbidities or other issues that kind of make anesthesia time more concerning. The other technique that we do, the technique that we actually do most commonly is called the TPLO, which stands for tibial plateau leveling osteotomy. And with this technique, we basically get rid of that hill or angle that we talked about and make the dog knee into the person's knee. So I have a model here. If this is a makeup of the dog's knee, this is the femur and this is the tibia. When you have a torn cruciate ligament, that lower leg is sliding back and forth like I explained. With the TPLO, we basically remodel the knee, realign the bones, and when we're done, they no longer can slide. The knee is still able to hinge, so we're preserving range of motion, but we're getting rid of that abnormal slide. This is actually a picture or a model of what it looks like. Again, this is the femur for reference, this is the tibia. We make a curved cut in the tibia based upon some very precise measurements that we take. We then move the bone into its new position and we hold it in its new position with one of these bone plates. This bone plate starts off as a flat piece of metal that I bend or contour to fit the particular bone. We then drill holes in the bone where the holes in the plate are, and then we put these bone screws in. So with the TPLO, the downside is that we're actually creating a fracture. And that's, again, one of the reasons why the post-op restrictions are so critical, because your pet will literally have a broken leg. This, however, this technique has really been shown to be a highly effective, depending upon the studies, most studies show to be the most effective repair for your bigger dogs and your more active dogs. So we tend to skew towards the TPLO in dogs that are over 60 pounds, dogs that have an athletic function, your working dogs, your active family pets, and so forth. With that surgery, the incisions on the inside of the leg, and again, closed with an intradermal pattern, goes home with a lampshade or cone. So it's a brief update or synopsis on both of the techniques that we use here at Hudson Highlands commonly. Obviously, we always do a full exam on the patient to make sure that we agree with the diagnosis and that these are appropriate, and we don't have an assembly line here. We treat every patient individually, so if there's any issues, anything different than what our expectations are, then we certainly give you a call and contact and go over what the options are so you can make an informed decision moving forward. Hope that answers most of your questions. We always will follow up if we do one of these videos with a phone call with me so I can address any specific questions that you have. But hopefully that gives you a brief view into the world of the cranial cruciate ligament disease in the dog and how we tend to fix it here at Hudson Highlands. Thank you very much for your time.